Bismillah ar-Rahman ar-Rahim. Today we will talk about arrhythmias. Arrhythmias are called abnormal rhythms. So what is the normal rhythm of the heart? It originates in the SA node, the rate between 60 to 100 beats per minute, and it follows normal pathway in the conduction system. Do remember when we say it will move from the SA node to the AV node, and there will be delay, then through the AV bundle, left and right bundle branches, then to Purkinje fibers. And it also should follow the velocity, the normal velocity of conduction in these parts. So this is the definition of the normal rhythm of the heart. Mechanisms by which cardiac arrhythmias can develop can be divided into either enhanced autorhythmicity, that's in the pacemaker cells, triggered autorhythmicity in the other cells, and re-entry in any part of the conduction or the cardiac system. And we will talk in more details about these mechanisms later on. So cardiac arrhythmias results from abnormalities in the rhythmicity or the conduction system. It may cause abnormality in the rhythmicity of the pacemaker, either increase or decrease. It may cause a shift of the pacemaker to be another structure in the heart, or it may cause a block in the conduction at different areas, or it may cause a spontaneous generation of impulses any part of the heart. There are many classifications for the types of arrhythmias. They can be divided according to the rate. So we can say they are either tachyarrhythmias, which means fast arrhythmias, or bradycardias, which means slow heart rate on the ECG. The other classification is anatomical classification, in which it can be divided according to the structure. There is an abnormality in it. So there will be SA node arrhythmias, there are atrial arrhythmias, AV arrhythmias or junctional arrhythmias, then ventricular arrhythmias. And also they will be subdivided into ventricular and supraventricular. Arrhythmias can be asymptomatic, or the patient can present with palpitations, dizziness and fainting, chest pain or shortness of breath, or even fatigue. The causes are variable, so it can range from congenital into acquired, resulting from either ischemia after myocardial infarction. Aging can result in changes in the cells leading to arrhythmias. Some infiltrative diseases or infections such as rheumatic fever, electrolyte disturbances, changes in the potassium and the calcium mainly. Some medications may induce arrhythmia such as digoxin. Iatrogenic causes, these are caused by the doctors themselves. For example, during catheterization, there might be induction of certain foci for the arrhythmias. Alcohol consumption, nicotine smoking, and caffeine may also induce arrhythmias. So now to diagnose patients with arrhythmias, ECG is a mainstay diagnostic tool that leads us to many information about different types and locations of the arrhythmias. We may need to use for temporary arrhythmias some monitors, or may use other diagnostic tools such as echocardiogram, electrophysiology studies, or MRI. The treatment depends on the cause of the arrhythmia, which can be either pharmacological, whether you want to increase the heart rate or decrease the heart rate, catheter ablation to get rid of these foci, implantable devices such as a pacemaker or a defibrillator, in addition to lifestyle modifications by stopping alcohol and nicotine smoking, limiting caffeine, and other. Now let's talk about sinus arrhythmias. They can be either tachyarrhythmias or bradyarrhythmias or dysfunction, SA node dysfunction or SA node block. Remember we said that the normal heart rate is between 60 to 100 beats per minute? If this heart rate becomes more than 100 beats per minute, then this is considered tachyarrhythmias. In the SA node, it can be physiological or pathological. So, for example, increase in the heart rate can result from strong emotions like anger and anxiety, or it can result from hyperthermia if you have fever, if you have blood loss or dehydration, if you're taking certain medications, or even drinking caffeine can increase your heart rate. So basically, anything that stimulates the sympathetic system can, or a sympathomimetics factors and drugs can increase your heart rate. Sympathetic stimulation can enhance the autorhythmicity in the SA node. As you can see here, this is the normal firing rate of the SA node. Once there is sympathetic stimulation, it can enhance the depolarization by increasing the influx of cations, such as the sodium and the calcium cations. You increase the slope of depolarization in these cells, so you can increase the rate of the discharge or the impulse generation in the SA node. That's resulting in tachyarrhythmias. It also may cause other effects in other structures in the conduction system. For example, in the AV node, cause decrease in the delay of the AV node, and within the atria and the ventricles, they will increase the strength and the speed of contraction. Again, this is due to increase the influx of cations. We will talk more about the mechanisms for that. Parasympathetic stimulation will have the opposite effect. This is a normal firing rate of the SA node. Parasympathetic stimulation will delay this thing by increasing the conduction of the potassium, leading to hyperpolarization. This hyperpolarization makes it difficult for the SA node to fire and therefore decrease the rate of the discharge, causing bradyarrhythmias or bradycardia. So bradycardia is the heart rate less than 60 beats per minute. You can see in this ECG strips that it's quite normal except for the heart rate. There are many causes of bradycardia that can either be physiological or pathological. For example, when you are sleeping, your heart rate will decrease. Elderly people are more prone to decrease in the heart rate. Athletes, when they are well trained, they also will have low heart rate. Hypothermia, hypothyroidism, these are all causes of bradycardia, as well as what we call it carotid sinus syndrome, in which when you do touching in your neck on the carotid sinus area and do kind of a massage, that will induce bradycardia. It can be used in different arrhythmias to help in the treatment of that arrhythmia. It is sometimes normal to have sinus arrhythmias, such as the respiratory type. So when you are taking an inspiration, then the heart rate increases. During expiration, the heart rate decreases. Actually, there is something called heart rate variability, which means that the heart rate, the time between the two consecutive hours shouldn't be exactly the same thing in all beats. There should be some kind of variability, a slight variability, because this heart rate variability reflects the balance in the autonomic nervous system. You see that the SA node is functioning under balance between the sympathetic and the parasympathetic impulses. So when there is this kind of healthy balance, there's some fluctuations in the heart rate. These are minor fluctuations, but we call them heart rate variability. In case of absence of this heart rate variability, that will reflect autonomic dysfunction. So SA node dysfunction, or what we call it sick sinus syndrome, is caused by impairment in the pacemaker function or the impulse transmission. So that will cause certain abnormalities of the rhythm, whether they are bradycardia, bradyarrhythmias, tachyarrhythmias, or sometimes alternating between both of them, in which we call it tachybrady syndrome. There is what we call it SA node block, in which there is a block of transmission of the impulse from the SA node to the atrial muscles, leading to atrial systole. You can see in this ECG that the QRS complexes are normal and the heart rate generally slow. So this is what we have, the SA block. Now let's move on to atrial tachyarrhythmias. Paroxysmal atrial tachycardia. This kind of arrhythmia starts suddenly and then it ends abruptly. It lasts for variable times, maybe a few seconds, few minutes, or maybe more. They may occur in different parts of the heart, and then they rapidly discharge, they become the pacemaker, and then when they stop, it will get back to the SA node as a pacemaker. We can treat this by using antiarrhythmic drugs that slow down the conduction and increase the refractory period. Or you may also do what we call it eliciting the vagal reflex by pressing on the carotid sinus on your neck. So with this thing you increase the vagal tone, so trying to prevent these paroxysmal atrial tachycardias events. Premature atrial contractions. These are contractions that happens at a time before the one expected for normal contractions. They also called extrasystole or ectopic beats. So they result from ectopic foci that cause the discharge at variable times. It's very common and may occur in healthy people, in athletes if you have lack of sleep, smoking, caffeine. They also can induce these premature atrial contractions. And premature contractions, when the heart contracts ahead of schedule, there is not enough time for the ventricles to fill with blood. So the stroke volume will be decreased or almost absent. And that means when you try to feel the pulse in the peripheral arteries, in your arm, in your wrist, you will not feel it, or you just feel very weak pulsations. And that will cause what we call it a deficit in the number of radial pulse compared to the actual number of contractions in the heart. So actually the heart is contracting, although not pumping enough blood, so that it cannot be reflected is in the atrial pulse that you feel it. That's what we call it the pulse deficit. Atrial flutter. See how it had very high heart rate. It's about 200 to 350 beats per minute. In this pathology, there is an important role in the AV delay at the refractory period, because these signals coming from the atria are very rapid. They reach the AV node, and then for the AV node, because of the long refractory period, they will not allow every single beats from the atrium to be transmitted to the ventricle. and so protecting the ventricles from very severe tachycardia in the ventricle that is very dangerous to health. And so you can see here that the ratio between the P wave and the QRS are about 2 to 1 or sometimes 3 to 1. You can see also in this ECG a characteristic appearance of this ECG. We call it sawtooth appearance. And you can see here the P waves are quite strong and very frequent. This graph showing the re-entry kind of mechanism within the atria leading to atrial flutter. So they are discharging frequently and rapidly, causing this what we call it atrial flutter. Atrial fibrillation. You can see here that there are multiple foci that cause discharge within this atrium that most likely to be dilated atrium. These foci will discharge in different directions at different rates, leading to asynchronous kind of contraction in the atria. On ECG, you can see atrial fibrillation, or what we call it AFib. There is high heart rate, but you can see here that the P wave have low voltage. That's because the activity of discharge of different foci are in different polarities, so they kind of cancel each other. You can see no P waves or very little P waves. The QRS complexes are quite normal, but they seem irregular. That's because these impulses reach from the atria to the AV node at totally different timings, resulting in ventricular contractions of different timings based on the refractory period of the AV node. Although this condition is not life-threatening, but sometimes we can be treated by synchronized cardioversion. The problem with this condition that it will cause, because there is no proper contraction of the atria, so decrease the efficiency of pumping of the blood by 20% in the heart. This is not a big deal, but the problem is this with the stagnation of blood in the atria. That may lead to dislodging of emboli to different organs in the body, especially the brain, leading to strokes. Therefore, patients with AFib, they are usually put on anticoagulants. That's it for this lecture. We will continue talking about arrhythmia next lecture, inshallah. Thank you.